All right, so next we are going to be talking about the SOAR method. So what is the SOAR method? It is stop, describe the scope of human trafficking, observe, recognizing verbal and nonverbal indicators of trafficking or dynamics of violence, ask, interacting with and aiming to identify individuals who have experienced exploitation through a victim-centered and trauma-informed approach. And then R, respond, identify needs and available resources, which provides additional support and assistance. So starting with stop. So identify and treating the immediate and long-term medical needs, referring to external resources and reporting when necessary. And then developing protocols for your workplace and work with community-based agencies that can meet the short and long-term needs of survivors. So this is something that you would implement, the stop part of it, at the beginning and initial interactions with somebody in your care. So through the screening process, through your initial conversations, asking about symptoms, what their home life is like, the initial screening and rapport building stages of working with an individual, and then also leading up to that, right? The behind the scenes work beforehand, those protocols in your workplace. What community-based agencies are around that you're able to partner with and have those conversations on meeting those needs for survivors of human trafficking. And then part 2, so observe the physical, behavioral, and environmental risk factors or red flags for trafficking. So physical, untreated work-related injuries, a high number of sexual partners, physical injuries or impacts of long-term trauma, or frequent treatment and or diagnoses of STIs or STDs. Again, these are not specific risk factors or signs of somebody having been trafficked, but they are factors that could cause a red flag for something else going on that could potentially be trafficking. I really want to emphasize the fact that none of these signs or these red flags or risk factors are going to specifically mean somebody is being trafficked. It just means that there is something going on that needs to be looked at more deeply, right? Because it could be something like this, but it doesn't mean that it is always going to be trafficking. Those behavioral pieces, confusing or contradicting stories, they're unaware of the location, age, time, or address, might be reserved or avoiding interactions and providing minimal information with you. They might be experiencing or exhibiting guilt, shame, or self-blame about their experience. That you'll see a lot in situations of interpersonal violence. Those environmental risk factors. So if they're accompanied by another person that answers for them or prevents them from speaking freely, if they're accompanied by a person that refuses to leave the room, or if their behavior changes in the presence of that person versus when that person is not in the room. If they are living at work or in overcrowded conditions, if they're not allowed to take a break at work or eat or drink on the job, and drink meaning like water or juice or something in that nature. If they're missing wages or being underpaid, or if they don't have documentation, right? Like a photo ID or insurance information. That one might be more if they maybe forgot it at home, but if they say they don't have one at all and aren't able to give you any identifying information other than their verbal name. If they're a runaway youth, or if they have frequent engagement in systems like the Department of Human Services, CPS, or other child protective related services and organizations. So let's test your knowledge here a little bit. So here's an example case study. So Nikita presented at the clinic alone, but appears quiet and only answers the minimum questions. She does not have any insurance documentation or proof of identification. She's unable to provide an address for where she is residing or any contact information for follow-up care. She expresses debilitating pain and shows the nurse a swollen and bruised ankle. And when asked how she received the injury, she says it happened at work. Her English is good. She easily understands the nurses and clinician when asked about her symptoms. And after about 45 minutes from seeing the urgent care physician, she asked one of the nurses how much longer before she can be discharged, stating she needs to get back to work or else she would get in trouble. So, what are some red flags in this story? Has to get back to work or else will be in trouble, no proof of identification, minimal answers to questions, right? She's a work-related injury, needs to get back to work, right? Again, or else she'll get in trouble. Yeah, really good things to point out. She has no address, right? Yeah. So there's more to this story than meets the eye, right? You guys pointed out some really good ones, some red flags that might be at play, saying that something is not all that it seems. Yeah, she could be homeless, right? That's another factor. We don't know necessarily what's going on. Maybe she's displaced. So Nikita came to the United States through a temporary foreign worker program as a domestic worker and was promised a job that included health insurance, a housing stipend, paid time off, and a salary of $1,800 a month. When she got here, her employer, Jacqueline, confiscated her visa and passport and said that she would get it back once she paid off her travel debts. She's been working for 2 months and has yet to receive a paycheck, and she's forced to stay in a room with one twin-size bed and a couch with 2 others in similar situations. They get fed 1 to 2 meals a day, and they do not get breaks. While on the job, she slipped and twisted her ankle, which made it difficult to continue working. Jacqueline told her that if she didn't get back to work soon, she was going to notify the authorities and have Nikita deported. Nikita decided to go to the nearby clinic and have it looked at. All right, so, and like I said earlier, these stories are examples. They do not represent a real person. However, they are based off of real experiences and accurately depict examples of trafficking in the United States. So as we can see in this story, Nikita came here with the promise of work that included health insurance, housing stipend, paid time off, and a decent salary. When she got here, her visa was confiscated. She doesn't have her passport, doesn't have any identification, claiming that she has a debt that needs to be paid. She's worked for months and hasn't received any type of compensation for it. The housing she's been provided is not adequate. It's cramped spaces. She doesn't get accurate or adequate meals. And she was threatened that if she didn't continue working, that they would contact the authorities. Right? There's always more to the story than meets the eye, and it's important to look at what those red flags could be and understand that something might be wrong, but jumping to conclusions can also cause harm here, right? Nikita is here through a worker program, but doesn't have the documentation needed. If this was to be reported right away, this could put Nikita in more trouble without getting the backstory to what might have happened, right? It's important to build that rapport so that way, if Nikita felt safe enough to disclose, she could share this information with her provider. So recruiter relationships, when we look at the cases of sex trafficking, it's really common for them to know their trafficker. 35% of them were an intimate partner. 25% was due to family, familial trafficking situations or an other relationship. And 16% of those were a friend, self-identified as a friend. These statistics came from the SOAR framework, which is where the material came from today. I have it cited at the end of this. It's a free training for individuals to go through if they would like to have a more in-depth training on this framework outside of the materials I'm sharing from it today. And then when we look at labor trafficking cases, we see much different results. As you can see, over 3/4 of individuals that experience labor trafficking experience that from an other defined person, probably an employer of some sorts. So when we look at trafficking, we see that there is significant differences in relationships to their trafficker and their recruiters, and how that looks for individuals. Somebody involved in sex trafficking might not feel as safe to disclose their situation because it's somebody they care about. It's their intimate partner. It's their family member. In one study, which I can share the information to in the comments, it found that I believe it was 60% of familial traffickers were their mothers, which was a shocking statistic that I had heard. And you can kind of see it play out here that, about half of those that experienced sex trafficking were by a family member or other. And my assumption would be in the other category would most likely be an employer of some kind or potentially a stranger. So moving on to the ask part of the SOAR framework. So understanding their circumstances, gathering information by asking questions, and avoiding asking details about their experience. This is not necessary to get them to be connected to help and or services. Using person-centered interviewing techniques is so important. You want to create a setting that is person-centered and trauma-informed. You want to discuss confidentiality, mandated reporting, right? We saw this earlier in a different section, right? Informing the client of the purpose of the question and how the information may be used, meeting the client one-on-one for parts of their visit, every part of the visit when possible, using a professional interpreter, and getting informed consent and having them understand what the consent exceptions are. And using a trauma-informed approach. Again, disclosure is not the goal. Prioritizing their sense of safety and well-being is. Assuring them that they don't need to share or retell their story is. So Josie's question earlier about what do you do if somebody does not want to share or retell their story to somebody else, but you are not the person that can provide them the most comprehensive care. Again, offering that education and resources, affirming their resiliency and strength, and letting them know that this can be a process done together, that they don't have to do this alone, right? You can help facilitate that soft referral or that warm handoff to other resources that can be impactful and provide that comprehensive care that's needed. Common mistakes you can avoid. So you want to focus on rapport and safety, paying attention to their nonverbal and verbal cues, monitoring their verbal and nonverbal cues and changes in conversation, and exploring different safety concerns with the patient. So instead of asking close-ended questions, you want to instead ask open-ended questions. So you can avoid asking, nobody's hurting you at home, right? Instead, ask, how do people in your household deal with conflict? Within the last year, has anyone hurt or hit you? Instead, you can ask, how often do people close to you use violence to solve their problems? Right? I would feel more comfortable responding to how often do the people close to you use violence, rather than asking, is somebody hitting you, right? It gives you the ability to have dialogue and to respond in your own words using your own experiences. I'm sorry to ask you these questions. We're required to at this clinic. Instead, you can say, I have a few questions that I am obligated to ask, and I want you to know that even though these are required, I care about your responses, and this is a safe place for you to share, right? It shows that you care, their response and answer is important to you, but you're also required to ask those questions. So that way, if they don't feel safe still, if they're too afraid to disclose, they know that this is a space where they can, but that's also a requirement of you to ask. It's not just you being nosy or prodding like was talked about earlier. You're doing it to allow them to feel safe and answer these questions honestly. So ask yourself these questions when you are unable to see a patient alone. When should I separate the patient from someone that I suspect could be unsafe to them? Right away, after a few questions, after you have seen the verbal and nonverbal cues and responses of the potential victim survivor and the person that might be unsafe. What are the reasons for my believing this, and are my own biases contributing to this, right? You have your own lived experiences that you are coming to providing care with. Are those impacting your assumptions that you might have on somebody that you might believe is causing harm, but are they really, right? What biases of your own are playing a role here? All right. So Liz in the chat says, I was once asked if I felt safe at home with my husband in the room. As a clinician, I know that they probably should have asked me that without him, but they need to ask it. And there was probably not a good way to ask him to leave the room since I came in there for an emergency. Yeah, right. It might not always feel like you can ask those questions because somebody else is in the room. If you need to ask and the harm doer is there and you ask, do you feel safe with the person sitting right next to you? More often than not, they're going to say yes, right? How can you ask that question otherwise? Maybe they could have said, why don't you tell me about the place that you feel safest and tell me about the people you feel safest around, right? You might not still feel as comfortable or might not feel like you can't say your husband. So in this example, you might have said, well, I feel really comfortable at home with my husband. But if you're not making eye contact, if you're looking down, if your nonverbal cues are giving away that you still might feel unsafe, that can provide a cue for your provider to then ask for your husband to leave and say, I'm actually really sorry. These questions are required for me to ask one-on-one. Is there any way you can step out of the room for just a few minutes? I can have somebody bring you up to grab you a cup of coffee, show you where the restroom is, right? Do it in a way so it doesn't feel like you're recognizing that this person might feel unsafe. Really good example there. Then who is going to separate the patient from their unsafe companion? Is it you? Is it security? Is it a different nurse? Is it a doctor, right? Ask yourself these questions and ask somebody else if you don't know what the answer to that is. And what safety measures do I need to ensure are in place if I feel this person is going to cause harm, right? Does your hospital require security before coming in the building? If it doesn't, and the person that's with them, you might suspect is dangerous, what does that look like? How do you address it? Is calling security a big event that happens in your clinic? Is there even security on site? What does that look like for you? In our office, we don't have security, right? We're an advocacy agency, but we have a panic button. We have a button that we can press and it automatically calls 911 and lets them know that there is a potential hostage situation going on. Have I ever had to use that? No, but that's a safety measure we have in place if we ever felt like the person we were with was dangerous or there was a dangerous situation happening. Is calling security a safe option for you and for your patient? If not, what other options are in place? Good questions to ask yourself and others at your organization if you don't know the answer to. So now we're going to test your knowledge a little bit with another case study. So Alexi, who identifies as non-binary and uses they, them pronouns, the 17, has been in and out of the foster care system for most of their life due to their mother's substance use disorder and their father being incarcerated. Recently, they've been placed into their third foster home this year. Alexi has come to the clinic for their annual checkup and you notice some bruising, redness, and abnormal discharge. You get their consent to test for any STDs and STIs and go over the health risks. They test positive for chlamydia. When using what you know so far about the SOAR method, what would be the next step in addressing your concerns with Alexi? We've talked about stop, observe, and ask so far. Ask. Yeah, what are some questions you might ask Alexi, or what are some conversation starters you might use to understand the situation more, get more information? Ask about partners, right? How many intimate partners have you had? Were these exchanges consensual, knowing that in the state of Wisconsin, any sexual encounter that involves penetration is not allowed under the age of 18. It's considered illegal. So anyone under age of 18 cannot consent to sexual intercourse. What are some potential red flags in this situation? Maybe ask about their home life. Yeah. What is life like at home? Third foster home, what is that like? What was the cause for maybe being removed from the others? Red flags of bruising. You would ask about safe people, who in their life is safe. Yeah. Abnormal discharge. Yep. What measures are you taking to protect yourself? Good question. Yes. Are you using condoms? If not, is there a birth control method you have in place to prevent maybe unwanted pregnancies? Yeah, methods of birth control. Awesome. STD prevention. Are those being used, right? Has anyone talked to you about this before? Have you had conversations about safe sex with people? Do you know what consent is, right? Good job, guys. Yeah, screen for ACEs. Thank you. Yes, right. There's already been so many indicated involved in the foster care system, mom history of substance use, dad is incarcerated. They're coming to the clinic alone. They have these health concerns that involve potentially unsafe sexual interactions. Yeah, good job, guys. Okay, we will come back to Alexi in a bit. But for now, we're going to talk about responding. So it is not single-handedly your responsibility as a provider to address and serve victim survivors of human trafficking. There are protective factors that decrease the likelihood of experiencing trafficking or becoming a harm doer, right? Using the public health response, individual resiliency, and survivor-informed programming. So the different protective factors that decrease the likelihood of experiencing or becoming a harm doer are substance use treatment, right? Conversations on substance use, not just abstinence only. I know that's usually a thing with sex ed, but it's also a thing with substances, right? What does it look like when you're prescribed something, when you are self-medicating? How can you find alternative coping skills? Skill development and vocational training, job readiness, employment opportunities, conversations about when is it a good time for you to get a job, and what does money management look like? Positive role models, coaches, and mentors. The number one thing that can deter a child from having experienced violence in the home to becoming a harm doer is having one safe adult. Community engagement. What are they doing in the community? Are they involved in sports team, extracurriculars, volunteer programs? Are they able to access those services? Increased awareness of trafficking and risk. Do they even know what human trafficking is? Or do they just know what they've seen on social media and what they've seen in movies, right? Then stable housing and household income. What does that look like for them, and what resources are in place for a child or somebody that does not have the cognitive ability to function independently at this time? What does that look like? Awesome. Coming back to Alexi. So again, these are fictional stories, but they are examples of real experiences that accurately depict trafficking. So since Alexi is a minor, you go over confidentiality and mandated reporting, explaining that you'll have to notify somebody about their positive test. Alexi becomes upset, doesn't understand the need to share this information, and says that the sexual encounters they've had were always consensual. You validate their feelings, explaining that none of what is happening to them is their fault. And you let them know that you are not here to judge, but you have an obligation to keep them safe. Using the SOAR method, what are some options you can give Alexi to help them navigate this situation? Advocate, yes. Now refer them to external resources that are able to provide them more comprehensive services than just their primary provider or the practitioner they're seeing. Yep. Yeah. So great job. You did the first option. You can offer to call an advocate to be with Alexi throughout the remainder of their visit. They agree, you can give them some space to talk confidentially for a while. And you can offer resources on human trafficking, discuss safety plans with them. Let them know that you are not there to get a disclosure or to get them into trouble. Go over your role as a healthcare provider and explain next steps thoroughly, right? The safety plan piece is so important. How can they stay safe after this disclosure and after the potential report that you have to make? And again, affirming that you're not there to get them in trouble. You're just there to keep them safe. And this is an obligation that you have as their provider. Awesome. Before we move into the next method that we'll discuss, which is the PAIR method, any questions on the SOAR method? All right. Okay. Do folks want to take a quick break? How are we feeling there? And we're going about an hour and a half since our last break. Okay, let's take 5 minutes and we'll come back at, let's do 2:15.